Questions will be transcribed, so we need those for the records. The speakers should all have disclosure slides, and with no further ado, I'd like to introduce my co-moderator, Dr. Alberto Chuslep. I'm Dr. Joe Beiske, and our first presentation is entitled Hiatal Mesh is Associated with Major Resection at Revisional Operation, and the presenting author is Dr. Michael Parker.
Good morning. First, I'd like to state that we have nothing to disclose. Then I'd like to thank Dr. Beiske and Dr. Chusleb for moderating this session. I'd like to thank Dr. Asman, Dr. Bowers, and Dr. Smith for their mentorship. And I'd like to thank SAGES for allowing us to present our data involving the use of hiatal mesh and its association with major resection at revisional operation. Currently, debate exists about the best method of closing the esophageal hiatus. And while the debate continues, mesh-associated hiatal closure appears to be increasing, and multiple methods of hiatal closure have been shown, and I'll demonstrate a few of these on the next slide. As you see, you can perform a primary closure with pledgets. You could also do a relaxing incision. Anterior or posterior bridging mesh can be done. Alternatively, an onlay or buttressing mesh approach. And finally, you could use a keyhole configuration. And there are many products on the market available for this technique, including on the left, submucosal-based, composite mesh in the middle, and a PTFE-based mesh. Proponents of hiatal mesh cite the ability to potentially obtain a tension-free repair. This is advantageous if you're faced with a large defect or a crura that appear to be weak. In addition, a fibrotic intense diaphragm can be better managed in this fashion. In addition, proponents of mesh cite the potential for a decreased recurrence shown radiographically based on swallow study. Opponents of mesh, however, cite the fact that an inflammatory reaction can occur from the periesophageal mesh as the esophagus moves during breathing and swallowing. This periesophageal inflammatory reaction from the mesh can lead to hiatal stenosis and, worst case, mesh erosion. Therefore, our aim in this study was to compare the perioperative outcomes that follow revisional surgery of the foregut between those patients with prior hiatal mesh and those with no prior hiatal mesh. Our study design was a retrospective cohort study where we identified approximately 91 patients of revisional foregut surgery over an approximate 3-year period. From these 91 cases, we excluded 13 cases performed for the indication of achalasia or for weight loss. This left us with 78 cases with a diagnosis of gastroesophageal reflux disease and/or hiatal herniorrhaphy. And 10 of these cases had a prior hiatal mesh. Our demographics are shown here. We collected age, of course, the gender, BMI, and ASA scores. But we also looked at the type of fundoplication failure for each patient, and we also noted how many previous operations were performed on each patient. Our primary outcomes in this study were to look at the need for major esophagogastric resection, defined as that which required a reanastomosis. In addition, we also looked to see what kind of fundoplication could be performed at revision, if any. Our secondary outcomes in this study were to look at length of stay, operative time, estimated blood loss, how many were done laparoscopically, how many cases were converted to an open procedure, and how many patients required blood transfusions during their hospitalization. This slide shows the statistical tests used to perform our data analyses. So we'll look at the demographics. Prior hiatal mesh is located on the left. Those non-mesh patients are here on the right. And what you note is that the groups are quite similar, not only with regard to their age, BMI, ASA score, et cetera, but also their type of failure. The percentage of anatomical failure was similar between the two groups, and the number of multiple prior operations, that incidence was also similar. When looking at these patients, we quickly looked to the radiographic study, the swallow study. And what we see is that you can find things such as in this patient, a slipness and fundoplication, as well as a paraesophageal hernia. This patient is given a classification of anatomical failure. But not all patients have radiographic abnormalities. In this patient, what you see is actually a reasonably normal appearing swallow study. However, this patient had some mild regurgitation as well as reflux and dysphagia. So in these cases, you need to look more closely at the clinical presentation, their endoscopy, and finally, take a look at the previous records from the patient, especially the operative report. Altogether, you can determine what kind of failure these patients have. And so I show to you here the different types of anatomical failure between the two groups. Again, incidence is similar. Paraesophageal hernia is the most common cause of anatomical failure for both groups. As expected, the incidence of functional failure between the two is similar, and these findings are in the absence of any anatomical failure. Now, with regard to the outcomes, we do note some differences between the groups. First, what you see here is that the patients with prior hiatal mesh had over an hour of extra operative time in comparison with those patients without mesh. In addition, patients with prior hiatal mesh had 3 times the estimated blood loss as those patients without prior mesh. These were statistically significant. The approach to the operation, the length of stay, and the requirement of blood transfusion was not different between the groups. With regard to our primary outcomes, there are 2 things to take note of. First, people with prior hiatal mesh were less able to have a complete fundoplication constructed at the revisional operation in comparison with those patients that had no prior mesh. But more importantly, patients with prior mesh were much more likely to have a major resection. In this case, 30%. This compares with 4.4% of the patients without mesh needing a major resection. These were statistically significant. Stated another way, the risk of requiring a major resection at revisional operation is 6.8 times as likely in those patients with prior hiatal mesh. And the type of mesh used, whether it was biologic or permanent, or the technique of mesh placement, whether it was as an interpositional mesh or an onlay, was not associated with outcome. Of course, as I mentioned, we looked at the number of prior operations. And in the non-mesh patients, the number of prior operations was associated with an increased risk of major resection, 4.6 times as likely. But in prior mesh patients, the number of prior hiatal operations was not associated with major resection, simply the presence of mesh alone. Therefore, in summary, the complexity and magnitude of the remedial operation is significantly increased in the presence of prior hiatal mesh. With regard to limitations, we recognize that this is a retrospective study. And we also note that we had relatively few prior mesh patients, 10, despite a relatively good volume of revisional cases, 78. In addition, no patients had their initial surgery at our institution. Therefore, we cannot comment on the type of mesh used or implicate the technique of mesh placement as a potential cause for their failure. And finally, our outcomes are only perioperative. Therefore, we cannot give longitudinal data that tells how efficient or efficacious our revisional operation was. So I'd like you to consider the path that a patient may go down when getting hiatal mesh placed during esophageal surgery. We know that mesh may decrease hiatal recurrence, at least in the short term, based on radiographic studies. But we also know that mesh does not eliminate recurrence. And furthermore, most importantly, mesh creates a significantly morbid path to remediation. Therefore, when a surgeon is faced with the possibility of using mesh at the esophageal hiatus, that surgeon must weigh the potential benefit of a decreased radiographic recurrence versus the potential complexity of remediation should a revisional operation be necessary. Thank you.
Floor is open for questions. I see someone at the center microphone.
Yes, good morning. This is Dr. Dmitry Olennikov, Omaha, Nebraska. Thank you very much for that presentation. I find that it's a very timely and important presentation. I think every surgeon in the room here understands that there is a risk associated with placing mesh at the hiatus. I have 2 questions for you. Question number 1, that the type of mesh or the technique employed bias the outcome in the negative. That is to say, if somebody was using Proliene mesh, then that spelled trouble 4 or 5 times worth if somebody was using, let's say, an absorbable biological mesh. And my second question is, surely many patients fail their initial Nissen fundoplication hiatal closure repair due to splaying of the crura, but many of those patients remain symptomatic due to failure. They're not just radiographic failures, as you suggest. In your study of the patients that presented to you that had failure non-mesh group, did they have symptoms, or were they all asymptomatic? I'm assuming they had symptoms, or you wouldn't operate. Thank you.
Thank you for your questions. To answer the first question, to the best we could, we looked at the type of mesh and we looked at the technique of mesh placement. From the 10 patients that we had that had prior mesh, 7 of those had operative records that were readily available. And from those 7, there were approximately 4 that had biologic mesh and 6 that had permanent mesh. And really, there was no correlation I could derive from the type of mesh or the technique of placement. I believe 5 were done as an onlay technique and 2 were done as a bridge interposition, and there was no correlation between those. Second question was regard to symptoms. Yes, these patients were symptomatic. All of them. The people with functional failure simply had no obvious radiographic abnormalities when we looked at their swallow studies. But they all obviously mandated an operation. So we separated the 2 groups. Thank you.
I'm going to use one of the Google moderator questions, and then we'll come back to the microphone. So the first Google moderator question is, what data exists about the experience or training of the index surgeon who placed the mesh? It may be that the worst complications in a referral center may not be a valid basis for condemning the use of mesh. In other words, that the original surgeon may perhaps not have done a good job. Do you know anything about where the cases came from?
No, I don't have a definitive referral pattern that I can give to the person asking the question.
Okay. Let's go to the center microphone again.
Karl Fuchs from Frankfurt, Germany. I have a similar experience, and I congratulate you to this analysis because I would like to support it, and that we have the same experience. My question is, we saw in our patients with a mesh prior set in that these patients had significantly more pain as a chief complaint, probably due to the rock-hard scarring at the hiatus, compared to the other recurrences without a mesh, where patients usually had more of a reflux pattern of symptoms.
Yes, we actually took a look at video samples of many of the patients that had prior mesh, and you could certainly note that there was a loss of flexibility of the mesh seemingly in all cases.
Center microphone again.
Barry Salke, New York. Congratulations. It's an eye-opening report, that is for sure, and it's been our experience at Sinai exactly the same that you said, with one exception, is that the biologics, we have not seen a lot of difficulty on revisional surgery with biologics. So, and we're told that this is material that disappears in 60 days, and it's remodeling and da-da-da-da-da. And that has been our experience there. But what I really want to know, what did you see with the biologics? What was the problem with the biologic? I could certainly understand with permanent mesh. We've seen that. Did you see erosions? What was the issue?
Actually, based on the video data that we have collected on some of these patients, I was able to view one of the revisions on a patient with prior biologic mesh, and I think the best answer to that is to say that the biologic mesh obscures the tissue planes pretty significantly, such that the dissection becomes much more difficult. And it's pretty obvious compared to the permanent mesh, where it's obviously more easy to see it. Doesn't necessarily mean it's an easy dissection, but the planes are different.
I think we have time for one more question.
Park from Baltimore. Appreciate your presentation, and a brief comment you might respond to. Our experience has been very similar to your own in terms of what we found, and so what we've actually moved to, we presented a brief video yesterday, is using the patient, a biological mesh, if you would, or a flap from the patient, we actually take the falciform ligament down, swing it down, and put it either not so much as a bridge, but where you'd put a biologic mesh. I don't know if you have any experience with that, you'd like to comment, but that's our standard mesh repair now, if you would.
I cannot comment on my group's experience with using that. I know members of the group have used the falciform ligament tissue flap for perhaps other things, but I'm not sure about that, so I appreciate that comment.
All right, thank you very much for that excellent presentation.